Hi. In this short video, I'll try to summarize the functions of autonomic nervous system in 10 to 15 minutes. It is a challenging task, but I'll give it my best shot. Now, looking at the structural classification of nervous system, we can divide it into central nervous system and peripheral nervous system. The central nervous system comprises of brain and spinal cord with its 4 segments: cervical, thoracic, lumbar, and sacral. Peripheral nervous system is the nerves which are coming out from the brainstem and the spinal cord, so cranial and peripheral nerves. We can also classify nervous system based on its functions, and that is somatic nervous system and autonomic nervous system. Somatic nervous system is the voluntary or the conscious nervous system. The examples are walking, talking, chewing, etc. On the other hand, the autonomic nervous system is the involuntary component, which is without our conscious control. Examples are beating of the heart, movements of the gut. All right. Now, in case of somatic nervous system, effectors are skeletal muscles. In case of autonomic nervous system, the effectors are smooth muscles, cardiac muscles, and glands. Somatic nervous system is controlled at all levels of the nervous system, starting from spinal cord all the way up. But higher centers play a major role. In case of autonomic nervous system, it is the hypothalamus which controls and integrates the autonomic nervous system. However, during emotional stress, higher centers can affect the autonomic nervous system. An example is, just before or during the exam, your heart rate goes up, right? Okay. Now, the autonomic nervous system can be divided into 2 major divisions: parasympathetic and sympathetic. In most cases, these two work opposite to each other. And depending upon the physiological status of your body, sometimes sympathetic division predominates, at others parasympathetic is dominant. Now let's quickly review the anatomy of these 2 systems. Parasympathetic nervous system, the nerves arise from the cranial component and sacral component. And sometimes it is called craniosacral nervous system. Okay? In case of sympathetic nervous system, the nerves arise from thoracolumbar segment of the spinal cord. Now I'm going to go into slight detail of these nervous systems, the structure and functions of both. Let's look at parasympathetic first. As I mentioned to you, it arises from the cranial and sacral segments. The nerves leave the central nervous system. They travel long distance before they synapse and then give rise to post-synaptic or post-ganglionic fibers, which will innervate different organs. In case of sympathetic nervous system, the nerves arise from thoracolumbar segments of the spinal cord. These are short nerve fibers. They immediately synapse after coming out from the spinal canal in the sympathetic ganglia, which are arranged on both sides of the spinal cord. Then postganglionic fibers arise, which travel long distances to reach their target organs. Let's look at some more details of the 2 systems here. As I mentioned to you earlier, parasympathetic fibers are long. They travel distances before synapsing with the second order neurons. The postganglionic neurons then supply the organs. In case of sympathetic, the most common arrangement, which I described in previous slide, is that there are short preganglionic fibers. They synapse and then they give rise to long postganglionic fibers, which will supply the target organs. And remember, the target organs in case of autonomic nervous system are smooth muscle, cardiac muscle, and glands. In case of sympathetic nervous system, there are some other arrangements. One arrangement is where you have long preganglionic fibers that reach adrenal medulla, where they synapse and they cause release of epinephrine and norepinephrine, or adrenaline and noradrenaline into the circulation. Third arrangement of sympathetic nervous system is where you have short preganglionic fibers giving rise to the long postganglionic fibers, but these fibers, rather than releasing epinephrine or norepinephrine, release acetylcholine at the end. Now let me go into detail of the receptors and which neurotransmitters are released at those receptors. Coming back to the same concept again, parasympathetic nerves, long preganglionic fibers arising from craniosacral segments of the central nervous system release acetylcholine at the end, which binds to nicotinic receptors on the postganglionic fibers. These postganglionic fibers are usually very short, sometimes within the wall of the organs that they are supplying. And then at the end of postganglionic nerve fibers, there is release of acetylcholine again, but this time it binds to muscarinic receptors, which are found on the target organ cells. And that will lead to the effects of parasympathetic nervous system on the organ. Sympathetic nerves, short preganglionic fibers, release acetylcholine, which binds to nicotinic receptors on the postganglionic fibers. Now, these postganglionic fibers are long. They reach the target organ. Now, they don't release acetylcholine there. They release norepinephrine, which binds to alpha and beta receptors on the target organ cells. Remember, we discussed in the previous slide the sympathetic nervous system has three different arrangements. This is the commonest one, which is shown here. The second one is where long fibers reach adrenal gland and cause release of epinephrine and norepinephrine into the systemic circulation, which will then bind to both alpha and beta receptors in various target organs, because these hormones are now in the blood, so they can reach a lot of organs, right? Third arrangement is where you again have short preganglionic fibers releasing acetylcholine, binding to nicotinic receptors on the postganglionic fibers, and then the postganglionic fibers reach all the way to sweat glands and blood vessels of skeletal muscles. In this case, there is release of acetylcholine, which binds to muscarinic receptors on these target tissues. Now, this is very similar to the parasympathetic nervous system, if you can compare. Yeah. So the final neurotransmitter is acetylcholine, not epinephrine or norepinephrine. In a nutshell, all preganglionic fibers, which are coming from the spinal cord or the cranial segment, they release acetylcholine at the ends, which binds to nicotinic receptors. Okay? But when you look at the postganglionic fibers, there are different neurotransmitters released. It could be acetylcholine, could be epinephrine or norepinephrine. And there are different receptors which they bind to. These could be either muscarinic receptors in case of acetylcholine or alpha and beta in case of epinephrine and norepinephrine. Now this brings me to share with you a bad news. So basically, there is no generalization one can use to explain whether sympathetic or parasympathetic stimulation will cause excitation or inhibition of a particular organ. Therefore, you must learn all the separate functions of these two nervous systems on each and every organ. However, there are certain generalizations that we can draw. For example, what are the situations where you will find sympathetic predominance? Some examples are when you are performing exercise, or when you are angry, or when you are experiencing fear, Also during fight or flight response. In these situations, the sympathetic nervous system predominates. What about the parasympathetic system now? Parasympathetic nervous system predominates during digestion, relaxation, and sleep. Now, after this brief overview of sympathetic and parasympathetic nervous system, let's look more closely on the neurotransmitters released and the receptors that they bind to. This will allow you in understanding the pharmacology of various drugs which are used very often in clinical practice. All right. So we saw there were two main neurotransmitters, acetylcholine and noradrenaline. Now, therapeutic manipulation of their effects is mainly aimed at, so what can we do? We can either stimulate or block the receptors. We can modify the concentration of neurotransmitters at their site of action. And this could be achieved by many different mechanisms. Let me list a few here. You can change the rate of synthesis of neurotransmitters, either increase it or decrease it. You can change the storage or rate of release of neurotransmitters from the synaptic terminal. You could either increase or decrease the concentration as a consequence. You can block reuptake of the neurotransmitter by the synaptic terminal. That will cause increased concentration of neurotransmitter at the synapse. You can block degradation of the neurotransmitter. Again, that would lead to increased concentration of neurotransmitter. Or you can change the number of receptors at the postsynaptic membrane. You can either upregulate the receptors or downregulate the receptors. So as you can see, by modifying all these different functions of either the neurotransmitter or the receptors, we can modify the autonomic response. Now let me share with you a bit of good news. If you know the receptors most drugs bind to and the distribution of these receptors, it's relatively easy to predict the effect of all these drugs. And as I told you earlier, autonomic drugs are very often prescribed in clinical practice. Cholinergic receptors can be divided into two types, as we saw earlier, muscarinic and nicotinic. How these receptors work? Nicotinic receptors are ligand-gated ion channels. So once the receptor is activated, it opens an ion channel, sodium mainly, and sodium goes into the cells. Muscarinic receptors are of various types. M2 are the most common receptors. I'm just going to mention M2. The way it works is through G inhibitory protein, which can cause either increase potassium conductance or a decrease in cyclic AMP inside the cell, which will lead to the effects in the target cell. Adrenergic receptors, as we saw earlier, are of two types, alpha and beta. Alpha are again of further two subtypes, alpha 1, alpha 2. Beta are divided into three subtypes, beta 1, beta 2, and beta 3. How these receptors work? When ligand binds to these receptors, which is epinephrine or norepinephrine, it will cause, in case of alpha receptors, activation of G proteins, causing increase in phospholipase C, eventually causing increased calcium in the target cells. Alpha 2 work through G inhibitory protein, decreasing cyclic AMP in the cells. Beta 1, beta 2, and beta 3, all of them work in a similar fashion. They activate G stimulatory proteins, increasing cyclic AMP in the target cells. Now, there are various drugs that act on these receptors. Let me give you some examples. So you can have drugs which stimulate the alpha receptor. We call them alpha agonists. Or you can have drugs which inhibit the alpha receptor signaling. We call them alpha antagonists. Same thing for beta. You could have beta agonists and you have beta antagonists. Similar for nicotinic and muscarinic. So you have stimulants, which are cholinergic drugs, and you have blockers, which are called anticholinergics. Now you can have either selective drugs or you could have non-selective drugs. What I mean by this is you could have an alpha agonist which blocks both alpha 1 and alpha 2. We will call it a non-selective alpha agonist. Or you could have an alpha agonist that only stimulates alpha 1. We will call that a selective alpha 1 agonist. I hope it makes sense. Now let me explain that to you with a clinical example. There are many clinical examples of how these drugs can be used. I'm going to share with you one example as an illustration. The effect of sympathetic nervous system and parasympathetic nervous system on the cardiovascular. Sympathetic nervous system, by activating beta 1 and beta 2 receptors on the myocardial cells in ventricles, causes increased heart rate and increased force of contraction. Muscarinic receptors are found on SA node, and activation of these receptors causes a decrease in heart rate and some decrease in force of contraction. What about the effect on peripheral blood vessels? In case of parasympathetic, there is no major effect except for in some special locations, for example, the blush area on the face. In case of sympathetic, there is a lot of effect on the peripheral vasculature. Alpha receptors are found in blood vessels, and by activation of alpha receptors, there is increase in vascular tone and there is increase in blood pressure. The main receptor is alpha 1, but there is also alpha 2 receptors present on the blood vessels which have a slightly different effect, but I'm not going into that detail right now. I'm just going to keep the example simple. All right, beta 2 receptors are also present in blood vessels, but they are not very many, and they have an opposite effect to alpha 1 receptors. So there is some decrease in vascular tone. But the main effect of sympathetic nervous system on peripheral circulation is through alpha 1 receptors, which causes increased vascular tone and increase in blood pressure. Now, there is a patient where heart rate is high and we want to bring the heart rate down. What can we do? We can block the beta receptors, right? We can give a non-selective beta blocker. When it blocks beta 1 and beta 2 receptors in the ventricles, heart rate will come down, force of contraction will also come down. All right? But there's a problem. The problem is there are also beta 2 receptors on bronchial smooth muscles. And effect of these receptors is to cause bronchodilation, smooth muscle relaxation and bronchodilation. If you give non-selective beta blocker to a patient who has history of asthma or is susceptible to developing asthma, what will happen? The non-selective beta blocker will block both beta 1 and beta 2, heart rate comes down, but at the same time, there is exacerbation of asthma because there will be bronchoconstriction. How can you avoid this? By giving a selective beta 1 blocker. That will only bind to beta 1 receptors in ventricles, brings the heart rate down, brings the force of contraction down without causing bronchoconstriction and exacerbation of asthma. Usually, you don't use beta blockers in asthmatic patients unless there is no other option, because although selective drugs are selective, but there is some cross-reactivity with other receptors. So as a matter of principle, this is an example which provides you with the concept that you can avoid certain side effects by using selective drugs. Okay, I hope I was able to convey to you the basic functioning of autonomic nervous system and how understanding autonomic nervous system can help you understand the pharmacology of drugs which are used to treat conditions where autonomic nervous system is involved. These are the references I've used in preparing this presentation. I would highly recommend you to read this topic in detail from your textbook and develop a good understanding, because this is an area which is very important in clinical practice. You will come across many clinical conditions, many pharmacological agents which are involving the autonomic nervous system. That's all from me now. Thank you so much.